So very good morning everyone. So as mentioned, I will be taking you through the management of eyelid lacerations and some of the basic principles. So basically the goal of any lid laceration would be to restore its anatomic integrity, to maintain the physiological functioning, and of course to achieve adequate cosmesis. So the primary goal in any eyelid reconstruction is to restore a functional eyelid that protects the eye and also permits normal vision. So furthermore, even a normal tear film maintenance is also another prerequisite. So the most important secondary objective, I would say, is a normal appearance because of the critical importance of the periocular region. So keeping in mind all of this, so the basic principles would be that any primary repair is always superior to a secondary repair. Now what is healing by primary intention? Basically that occurs when the wound edges are approximated by sutures or staples or even glue, and secondary intention healing takes place when the wound edges cannot be approximated, so you allow it to heal from bottom upwards. So always primary repair remains superior to the secondary repair, and any injury should always be treated as an emergency. A first hand treatment should always be propagated. It is always mandatory to examine and treat the patients for all kinds of injuries. Next, a high index of suspicion for any undetected injuries should always be borne in mind, and it is equally important to also document all injuries very carefully, especially in medico-legal cases. Now the general principles to follow when you're treating any lid laceration would be to maintain adequate wound hygiene. Next, it is always mandatory to perform a correct anatomical alignment, and also no tissue should be excised or discarded unnecessarily. Always try to approximate it such that the anatomy of it is maintained, and it is mandated to always initiate the surgical repair within the first 6 hours to less than 24 hours in order to achieve maximum approximation and better cosmesis, and delay of any major reconstructions is necessary only if the expertise is not available. So now the spectrum of trauma is variable. So here just to take you through the different pictures present here. So there is marginal on the picture to the top left, where the entire margin of the eyelid is involved. Extramarginal, which spares the margin and involves the periocular area. There could be avulsed wound when the wound is ripped off its anatomical adhesions associated with a tissue loss. Also, it is equally important to assess the wound which has occurred with, the source of the trauma. That is, it could be a sharp object, it could be with a blunt injury, it could be any animal bites, and also it could be secondary to ocular burns. So for all of this, initially, obviously it is very important to be well versed with the anatomy of the eyelids. We are all aware that the eyelid has an anterior lamella which mainly has the lash line, and the gray line, and then the posterior lamella which mainly consists of the tarsus and the conjunctiva. So knowing the anatomy and its various adhesions in the periocular region is of utmost importance in order to initiate any form of closure. Now repairing the wound in layers as deep and superficial always provides better tension as opposed to repairing it with just a single layer. So as shown over here, in the image to the top, we can see that there would be a lot more redundant skin, there wouldn't be significant tension, and it would also lead to more of upper eyelid skin fold formation. Whereas if the wound is closed in layers, that is taking the deeper bites as well as the superficial bites, significant tension would be maintained. So primary closure with undermining is another key, especially for wounds which are involving the periocular region. So primary closure with undermining is commonly used to close lesions which are away from the lid margin, like I mentioned. You must know the level to undermine to mobilize the tissues along with preserving the blood supply and avoid any sort of nerve damage. So also keeping in mind the danger areas for the facial nerve, because you wouldn't want to inadvertently injure the facial nerve, especially over the zygomatic arch or in areas which are just lateral to the eyebrow. Another important thing to be borne in mind, especially while suturing the lacerations, would be to maintain the method of halving. So here always divide the wound into halves, equal halves, close at the edges and the center, and then continue to close them by dividing each of the remaining wound into halves. And any dog ear, as demonstrated here below, should always be trimmed off and sutured accordingly. Now, like I mentioned, secondary intention healing is where there wouldn't require any sort of suturing, and the wound healing is just allowed to heal by itself from bottom upwards. So here it can be done in areas where there's adequate tissue laxity and also normal wound healing potential, especially in healthy individuals. And small anterior lamellar defects, usually closer to the margin or the medial canthus, can be allowed to heal in this manner. So now when we come to the suturing techniques, it is always important to keep these things in mind. Always assess how deep the wound is. So for deeper wounds, it is important to close the dead spaces, of course prevent hematoma collection, provide wound stability, and also remove the tension. Now the superficial layers, it's always done to maintain the proper wound alignment. So for wound, once you have assessed the wound, it has to be closed in layers, the deeper layers and then the superficial layers accordingly. So let's just try and get into the assessment of the wound by dividing them into partial thickness or full thickness depending on the depth of involvement. And then coming to the planning, where would it oppose very well with just a direct closure? Would it require grafts or would it require flaps? And also assessment of the horizontal length of the defect. So in the picture demonstrated here, it is very important to first clean the wound adequately so you're able to assess the extent of involvement. And also you must know the level to undermine and to mobilize tissue to preserve the blood supply and also to avoid nerve damage like I mentioned. Within the orbital rim, any tissue undermining should be done in the preseptal plane, and outside of the rim, undermining should be done in the subcutaneous tissue plane. And it is always, especially one needs to be careful while undermining any tissue in the path of the seventh nerve, which usually extends from the tragus of the ear to the tail of the eyebrow, like I mentioned. So when we talk about full thickness defects, they can be divided into less than 25%, that is involving less than 25% of the eyelid margin. So these can be sutured by a direct repair following the far near pass. Now what is that? That is usually kept in mind taking the meibomian orifices. So you suture at least the far bites are taken about 4 meibomian orifices on either side of the wound, and the near passes are taken on 2 meibomian orifices lateral to the wound on either side. So tarsal sutures, taking the bites through the tarsus, is extremely important because this allows the wound stress to be distributed evenly, and also wound dehiscence is decreased and lid notching of course is reduced. So this is just representative images showing full thickness marginal wound which is less than 25% and how the tarsus is also involved and how it has been sutured. Now for extramarginal lacerations, it is important to maintain the skin tension lines. So now what are these skin tension lines? These reflect internal tension within the skin. So they represent the direction of maximum skin tension line. That is, so to say, they represent the direction of orientation of the underlying collagen fibers. So any defect or any wound that is in parallel to this is allowed to heal in the same direction. So always for extramarginal lacerations, the healing should be done such that, or the closure should be done such that they're along the lines. Now coming to full thickness defects, which are 25 to 50% involving the lid margin. So in these cases, usually one has to mobilize to allow for direct closure. So that can be done by doing canthotomy and cantholysis, which increases the mobility of the eyelid skin. And then again, by suturing it with vertical mattress sutures, the approximation can be achieved. Similarly, a Tenzel's flap can be harvested and then it could be closed. So secondary repair is also important because you have to take into account the cosmesis. Any sort of lag of thalamus which would precipitate to exposure keratopathy should be borne in mind. Eyelid malpositions and trichiasis should all be kept in mind so that you also correct it along with suturing the lid lacerations. And also it is extremely important to look for any presence of any foreign body, any medial and lateral canthus deformity, any coexisting ptosis, because you would have to counsel the patient accordingly and achieve adequate correction. And also any overlooked canalicular injury, this becomes a mandate. Any injury which is medial to the puncta, one should always rule out a canalicular involvement. Another important aspect of any periocular injury are animal bites. So here it is important to classify the wound and also keep in mind the anti-rabies vaccine schedules. So here wound cleaning with running water, hygiene is of extreme importance, and also of course systemic antibiotics.
Priyanka, just pause a little bit, the slides are not visible.
Okay.
Yeah. And audiovisual team, please try less of interruption in between the presentations.
Yeah, so I'll just quickly take you through these last few slides. So in all of these, like I was mentioning, animal bites, we stopped at that. Now, other important aspects while dealing with periocular lacerations are to maintain the tissue planes. We've already discussed that, but these are just representative images which are showing that primary closure with undermining is commonly used to close lesions which are away from the lid margin. So one has to keep in mind to look for any tissue loss, to look for the extent of involvement, and maintain tissue planes, because the mobility needs to be maintained once correction is achieved. So it is also equally important to look at the other normal side in case the other eye is not affected and the other periocular region is not affected, so that you have to so that proper the lid lacerations can be repaired with proper orientation. And also any underlying tissue damage should also be looked at and examined in detail. And the most important, like which I already highlighted, it is important and it is almost mandatory that any injury which occurs over the medial aspect, one should always rule out or bear in mind of an associated canalicular repair, and it should be accordingly addressed. Thank you so much for your time.